All right. Good afternoon, everyone. I am so happy to be here with our illustrious panel. My name is Dr. Courtney Ray, and I am the founder of Array Psychological Assessments. I am a clinical neuropsychologist based in New York, and I serve the New York and Northern New Jersey area. It is so great to be able to have this panel here. Today, we are talking about mental health care and just the entire spectrum. I think we have a representative from, I can't say every field because I'm sure there are other mental health fields that I'm not aware of, but we have a good spectrum, a good broad group here. One of the reasons why I wanted to do this is because as a clinical psychologist, I get a lot of calls from people. There's three reasons. One is I get a lot of calls from people who are looking for somebody and they're asking for someone to do things that are not the things that I do. And I find that a lot of people really are unaware of all the different kinds of mental health professionals there are, and they kind of think they're interchangeable. So I often find myself having to explain, no, this is not what I do, but I know somebody who does do what you need, and referring them out. So this is for the general population of people who wants to find out about who they can turn to for their mental health care needs. Also, I want to be able to help those people who are looking for a mental health career. I work with students. I have a lot of students who will come to me, or people who are looking for a second career who want to find out about what their options are in terms of mental health professions. And so sometimes people say, I want to do what you do. And then when I talk to them, I'm like, no, you don't want to do what I do. You probably want to do this or want to do that. And so this is educational, hopefully, for someone who might be interested in working in mental health and to see some of the options that they can have. We're in graduation season. And so I'm sure there's a lot of seniors who are looking towards what they want to do in their rest of their career. So this is a good way to get them some just a little snapshot of what kind of options they might have. And then, thirdly, there are lots of professionals who work in either mental health care or in ministry or in medicine who have the ability to refer people and can share with other people what we do, and they don't know all the different things that are available. And I hope that if you are watching now and you do have the ability to refer someone, that you'll learn from this panel about what are the people that are available to you, who are the people who are available to you. I often, when I worked at a hospital, have sometimes had to explain myself over and over again to other healthcare professionals. And I've even said this afternoon that we're going to learn from each other because I'm going to have the opportunity to learn from all of our guests about the things they do. So I've talked enough for right now. Let's go ahead and actually hear from our panelists themselves. I'm going to just go in alphabetical order and ask you to tell us what is it that you do. So I'm going to ask you to introduce yourself. Let us know what your field is, where you practice, and what population you serve. So, Mr. Audain.
Yes, my name is Jean Audain. I am a licensed clinical social worker. I practice social work in the state of Maryland. I work for the school system. My title there is a programmatic school social worker, and what I do is I manage an outpatient mental health care um, system that provides healthcare, mental health care services to the students of Howard County. My responsibility is about 4 schools. I share that responsibility of finding students that need healthcare and then linking them with our outpatient mental health clinics. I also have a small private practice that I see anywhere kids ages from 5 all the way to adults. I have a small staff that we essentially work with young people and young adults and some regular aged adults as well. My specialty is adolescents. That's where I've spent the majority of my career has been spent in schools, and I'm still in school. And yeah, that's pretty much my niche.
Awesome. Awesome. Glad to have you. Thank you so much.
Thank you.
We definitely want to hear a little bit more about social work and kind of get to some of the myths that social workers
Yeah.
might face and what people think about what you do. Dr. Banjoko.
Right. So my name is Dr. Sandra Banjoko, and I'm a licensed marriage and family therapist, and I practice in the state of California. I am also an assistant professor and program director of the Masters in Counseling program for the LMFT and LPCC track at Garcia University. And I specialize in what I specialize in is sex therapy in particular, and working with cultural issues and issues with people of faith and like other spiritual issues as well. And let's see, I also work with eating disorders. I used to do that full time for a bit, and then I kind of went into sex therapy. And so that is what I am currently practicing right now.
Awesome. Awesome. Very interesting. I know we'll have some questions about that in the
Mhm.
chat. We're going to go on to Anthony Garcia. Go ahead and tell us who you are, what your field is, where you practice, and what population you serve.
Awesome. Hello, everyone. Thanks for having me today, Dr. Ray. My name is Anthony Garcia. I'm a licensed nurse practitioner. I work for University of Texas, UT Health Houston. We serve primarily Houston, but some of you know it's a pretty big city. There's a lot of surrounding areas that we serve as well, some through telehealth and that sort of thing. I work primarily in sleep medicine. My connection to the mental health field is providing cognitive behavioral therapy for insomnia, which a lot of you are familiar with cognitive behavioral therapy, but ours is just different a little bit in that we focus just primarily on insomnia, and I work with primarily adults.
Okay.
I think that was it,
Great.
right?
Yeah. Yeah. That was
Thanks.
everything. All right. Miss Karla Lawrence.
Hello, thank you for having me, Courtney. My name is Karla Lawrence, and I am a licensed clinical professional counselor, a board certified telemental health professional, as well as a certified professional coach. Um, I practice in Maryland. I have a small independent private practice where I provide both professional counseling and life coaching services to adults 18 plus who are wonderful at caring for everybody else in their lives and are not great at caring for themselves. So, as you can
That
imagine,
might be everybody here.
so I have a really big heart for like my teachers. As my initial career was in elementary education, so I have a really big heart for my teachers, my fellow mental health providers. I also provide support for folk who have challenges around their food and body relationships from a health therapy size aligned perspective.
Mhm.
And I also have a big heart for late identified or diagnosed neurodivergent folk. Um, so, yeah, so there's a little bit of breadth in the work that I do, and providing both life coaching and counseling allows me to support people kind of across the spectrum of experiences.
Awesome. Awesome. Very interesting work. Interesting. And Dr. White.
Hi, my name is O.C. White, and I'm a child and adolescent psychiatrist. I work primarily for the County of Los Angeles in the Department of Mental Health in the Specialized Foster Care Program. I've been in that program almost 18 years, and it was, so I think it's a great program. It's one that was developed out of a lawsuit, a class action lawsuit against the Department of Children and Family Services and Department of Mental Health for not providing adequate mental health care to the foster
Mercy.
population. And so over the last 18, 19 years or so since that program was established, we've been developing ways of really trying to come up with a better system to address those needs. I love that job. I enjoy the fact that, we have some flexibility with, we do a lot of field work as well. I don't just see clients in the office. I go to the schools, to the homes, group homes, wherever required. And to try to just meet the needs of that population, which are challenging for different reasons. We can go into it later, possibly. But
Yeah. All right. Well, as I've said to you guys before we got on, I know a lot of you for years, most of you for over a decade. And when it comes to our resident social worker and our life coach and counselor here, I have known them since the last millennium, since the 1900s.
Yes.
And so I am but I'm interested in finding out all the things that you actually do on a professional basis instead of just our personal connections. Those of you who may not know, I am a clinical neuropsychologist, so I am a psychologist, but I have a specialty in neuropsych, which means that I do assessments, and the population that I serve is from childhood all the way up to adulthood. And most of my population that comes to me is usually parents bringing their kids or kids bringing their older parents to come and get assessed. But I also do work with anybody in between that, and as well as I do a lot of assessments for people in the jail system. So I will go to a federal prison and do neuropsych assessments there. And so when I'm working with federal clients, I go to wherever they are. But my local office is in, as I said before, Northern New Jersey and the New York City area. But I also have what's called PsyPac, where you can do telehealth with people from other states that also are in the PsyPac agreement. So there's also the telehealth option. So that's what I do. So getting to know you guys a little bit better and what your fields are better, what are common misconceptions about your field that people may have? And if you don't know any misconceptions that come to the top of your mind, I have some that I wanted to find out. There's even a couple of things that I asked you guys during the time when we were texting in the planning of this. I was asking you some questions about things that I didn't know in what you did. So, what are some misconceptions that you might hear? And we'll go in reverse order this time. So, Dr. O.C. White, go ahead. What are some misconceptions?
I would say probably the most common misconception that we have to combat is that a pill can fix anything or everything. Yeah. So that would probably be one of the where the educational component comes in as to really what our goals are if we're looking to use medication, and really providing a lot of education about the non-medication interventions that I usually almost always recommend first and try to work through, and I like to perceive medication as kind of a last option if necessary, for certain reasons, but just that thought that well, because I'm taking a pill that'll like solve the problem, when most of the problems usually require multifactorial pieces to resolve.
Last resort. Now, what I've always heard is that you guys are, this is not for me, but I always hear that psychiatrists are pill pushers. You get a kickback from big pharma, and so
I guess that would be the other misconception, that I hope is a misconception. I probably am, working as a child psychiatrist, and just from my background, I'm probably more conservative when it comes to medications than maybe the average psychiatrist. But I mean, in psychiatry, we are, not usually looking just to address medications only. For most of us. So, really getting a nice conceptual picture and figuring out what are all the things in play that are causing whatever concerns that are, each individual might be presenting with, and then what is a, total, package, that we can kind of recommend of how we can address any of the problems and stuff. And then really, present, I personally like to present medication as an option that is often, it's a tool that is often helpful, but it's individualized. It's not just because a particular diagnosis or something might be present doesn't necessarily mean that a medication is necessary or is the best option. And severity and impairment are things that are going to be in play, and whether or not the potential risks that come with using medication outweigh the benefits that we expect. Those are that's the balance we're looking for in any individual case.
Good, good. I'm glad to hear that there's a holistic sort of
Mhm.
care aspect. All
Right.
right, so let's hear about life coaching and counseling. What are the misconceptions most people ask you or tell you?
Oh man, that's so funny. At this point, I feel like by the time people get to me, they're like, I want to work with you for stuff. So that one was a little tricky for me. But I think um, that, you know, we have the answers and we'll fix it and tell them, I think is one common misconception. And, how I work with clients is a collaboration, it's a partnership. And my hope really is to lead my clients back to themselves, to
Mhm.
help them identify the answers that they have within them and explore and kind of heal the places where they've become disconnected. And kind of healing on the counseling side, and then I think on the coaching side, and coaching is incredibly broad. um, on the coaching side, I would say part of what I want to do, since the assumption is that kind of mental health is in a good place and that's not what the need is, um, it would be helping them to kind of accomplish something. There's
Okay.
some sort of specific goal or need that they have. It could be in terms of business development. I've absolutely done some business coaching. Um, and across the board, the high work is about kind of centering the self. And so, how we can kind of operate in our lives from sort of a centered and self connected place. So, it
Okay.
might be, how do I center myself within the context of my business work, or how do I kind of move more effectively in certain aspects of my life that maybe are even good, but I want them to be better. Um, yeah.
I know for a lot of people, the first instance or familiarity they've had with coaching is from Alanya Van Zant, Fix My Life. Like, how much of
Mhm.
that is, is really what it's like, or how much of that is sensationalized for reality TV?
Yeah, I would say that's probably a little bit sensationalized for a TV again. And I, just have access to my experience, and I'm trained as a counselor first. So my point of view is going to be a little bit different, but yeah, it's important for you to know what you want. I think very much for coaching and counseling to be effective, you want to know, like, what do I want here? What's my goal here?
Mhm.
Um, on the counseling side, if people are a bit unclear, I do kind of provide support in terms of helping them find language for that. I do take that as sort of part of my responsibility, because sometimes people just don't know.
Mhm.
They just know things aren't working and they want to feel happy.
Yeah,
And
yeah.
sometimes that's all they know, and that's the language that they have at the time that they come in. So I try to then help them get more specific language, like, well, what does that mean, and how do we define that, so we can help you get what you want. So,
All right.
mhm.
Awesome. All right. So, nurse practitioners, what are they? And what do people think you are, or what what you do?
Well, I guess working in sleep medicine, I think the biggest misconception is kind of piggyback off of OC is that we just hand out sleeping pills. And I think that's kind of probably what I thought too before I got in the field. But, part of the reason I'm here is kind of hopefully educate on, um, the gold standard for insomnia now is actually cognitive behavioral therapy for insomnia, before medications. And I don't think a lot of people realize that. So, anytime I meet a counselor, I always try to recommend, did you know that this is a thing? Please get certified. That's part of the problem is there's, who doesn't have sleep problems? And there's just not enough providers out there. And a lot of people think there's just a magic pill to fix it. And and there's kind of what everybody else was saying, it's a lot of work that goes in behind it. And um, hopefully the idea is to get people off of medications.
Mm, awesome, awesome. And so, like, a lot of people think that I know that when people hear the word nurse, there is a kind of one picture of what a nurse is, but a nurse practitioner is different from an RN and different from an LPN and all that. So
Sure.
what are the differences?
Well, I think the biggest misconception in that area specifically is that I'm a doctor or I get called doctor all the time. I'm probably a lot more because I'm a male, I think, but I want to not take anything away from medical doctors. There's a lot more training and education that goes into that. One of the things that I don't know, I'm a little partial to nursing is that we do focus on, a lot, primarily on the patient and patient-centered care, and a big part of it is education. Um, and I know that kind of translates to different areas, but um, so yeah, we can prescribe, we can diagnose, but definitely not a doctor, and maybe a step above a nurse. And it is a master's level, a field, sort of master's is required as opposed to nursing is you can get it with an associate's or a bachelor's, and then doctors, of course, doctorate and much more schooling. So.
Okay. All right. So, Dr. Banjoko, tell us about marriage and family therapy because there, I'm sure, are lots of things that people believe about MFT that is not reality.
Yeah, thank you. I just like what everyone said, like that you're gonna come see me and everything is gonna be fixed, and I'm gonna give you all the advice, and you're just gonna run into the fields and gallivant. I think in terms of MFT, I think another misconception is that we just do marriage and family therapy. Actually, there's some conversations in the field that we need to restructure what our name, but it's really that we were trained in doing things systemically,
Hmm.
meaning that we were trained to look at that a person doesn't just happen to develop in a vacuum, and what are the things around you that contribute to who you have become and the issues that you are struggling with. And so instead of just focusing on you as the individual, we actually have to know your family of origin, your friends, your systems, your church, your religion, like all the things that make you you, all the intersectionalities that you carry, and how each part of you is showing up in you. And kind of like what Carla said, like bringing you back to yourself and trying to create a space where you can show up as your authentic, full self and not in fragments. That's the whole goal of therapy in itself. But yeah,
And just like you said, a lot of people think that you only do families and or marriages.
yeah,
Can individuals come to see you?
absolutely. I actually do. I do a lot of couples, but I actually see a lot of individuals. So
Okay.
again, the only reason why we're called marriage and family therapy is because we're trained to work with systems.
Okay.
Like our
All right.
big focus is working with the system.
Cool, cool.
Mhm.
And social work. Now, I know that there's a lot of things that people have conjure up in their minds when they hear social workers. So tell us about what is myth versus reality when it comes to social work.
Well, Courtney, you're correct. There's a lot of stigma that comes along with social work. First, we operate only in the Department of Social Services. We break up families. We take kids away.
Yep. You take
That's
away,
probably
snatch those children.
right. I know OC, who's worked with the population, understands that.
Yep.
We work with people with financial struggles as well. That's the only places that we exist. Oftentimes in school systems, we have all the answers. This is a similar theme that I've heard from a lot of you guys, right? And we help people with financial struggles. We fix things. We're seen as fixers. We work alone, right? We don't need the help of anybody else. The social worker's here. Okay, everybody can show. You're on vacation. Everything's going to be taken care of. We get or we give help. Those are often probably the most common misconceptions I hear. But what I'm hearing from a lot of people, there's a lot of similarities. We look at the entire system altogether. We look at humans psychodynamically as well. Some of the tenets of social work are service, social justice, dignity in the worth of the person, importance of human relationships, integrity, and competence, right? So these are the major tenets, the major parts that we work from, and relationships are key. So if a social worker is not good at relating to you or the clients, they're not a true social worker because that's a huge part, of who we are and what we do. And if there's no relationship, we're not doing our job.
Awesome. Awesome to know. Awesome, awesome to know that you're not just there snatching up people children.
Yeah.
Well, I know that for me in psychology, two big things that I often hear are, oh, and this happens anytime. Am I going to have to come and lay on a couch? That's like a big thing that oh, you lay on the couch and the the psychologist is going to sit there and take notes, and then they're going to give you advice. And that's, I think, a big issue that people have when they think about psychology and psychotherapy in general, is that they believe that it is advice giving, and I'm going to tell you what to do. And I gotta say, when I was younger, I actually thought that as well. Like, the first time I went to go see someone, I came and I was like, okay, so this is my problem. Okay, so now, give me the advice that I need. And that's not what it is. It's about listening to you, finding out what are your needs, what are the things that you are presenting with and your presenting problem, and then also helping you to find out the solutions. I'm not going to fix you. As many of you guys have said as well, this is a partnership. And I've also heard, especially from people of faith, that they are afraid to go to psychotherapy, and particularly psychologists, because they believe that what we do is tell them or try to convince them to either leave their faith, which is very weird that people think that. But a lot of people feel like we impose our beliefs onto the person who's in front of us, and we don't. Our job is to meet you where you are, find out what are the things that are important to you, find out what are the social and psycho and biological and psychological makeup that will contribute to all of the things that will help you get to an adaptive place. So that, I think, is really important for people to understand, so that they don't go in fearful or avoid us because it's not like you see on TV. TV has done a horrible job at educating people about psychotherapy, and has for decades. And so don't be scared because of what you may have seen in a movie or television, because it is a relationship, it is a dynamic between, just as Jean said, where it's the relationship. If they don't have a good relationship with you, then they're not the person for you. And, sometimes you might find somebody who isn't the person for you. That doesn't necessarily mean that they're a bad person, but it just means that they're not the one for you, right? Like, just like in dating, or finding a hairdresser, or finding any other kind of person who provides a service. Just because you don't have a connection with them, that doesn't mean that they're bad or that you should give up. Totally. It just means that you just have to find somebody who's a better fit. And that's what I think I want people to know most of all about psychotherapy in general, and psychology specifically. And I also want to hear from you guys. What is distinctive about your field's approach, or a specific niche that's different from the other health fields? Because I hear all of us saying much of the same thing in terms of what people think we do versus what we actually do. So now I want to find out what kind of differentiates us from each other, in terms of what are the things that your field specializes in that may be a little bit different from some of the other fields that we've heard from. So we'll kind of mix it up a little bit. I'm gonna go first to Karla. Go ahead and tell us what is it? What's the difference between what you do and what everybody else does here?
Okay. So professional counseling came through the School of Human Development and Education. So in my program, and I apologize if I'm skipping ahead to another question, but education-wise, that's a little bit different. So our training was specifically counseling. So all of our classes were geared towards providing counseling services to across the spectrum of people. I would count it more of a generalist counseling degree, but very targeted on that. So we have a lot of hours of clinical work that we do and supervised practice that we do to make sure that we are providing, supportive and appropriate care when we sort of get out there. Yeah. So that's kind of the top thing that comes to mind in terms of a little bit of a distinction on the education side of the coin.
Okay. All right. Anthony Garcia, go ahead. Tell us what's different between what you do and what everybody else here does.
So I think maybe kind of mentioned it a little bit earlier, but I know a lot of people here and probably some listening are familiar with, cognitive behavioral therapy is a, a pretty common form of psychotherapy that, focuses on changing, our negative thought patterns and behaviors to improve, mental health and well-being. But what we, focus primarily on is, insomnia. And one of the, I guess probably my favorite part of the treatment is a lot of based around the, relaxation techniques. And really it all comes back to meditation without really calling it meditation, but, just focusing on our breathing, guided imagery. There's some yoga nidra. I don't know if anybody here is familiar with, but nidra meaning sleep, a form of yoga where you're laying on your back with your eyes closed. So I think maybe that's what distinguishes us the most, but I'm not really sure if there's anything else I could add to that, to be honest, but thanks.
Okay. All right. Dr. White, go ahead. Tell us what's different about psychiatry versus any of the other folks here.
I would say that one of the unique, special, things about us is that, is our particular focus on the biochemistry of the brain and how to manipulate that with the goal of trying to improve mental health. So I would say that's probably the biggest differentiator with that.
Okay.
To answer your question, like just straight up.
Yeah. All right. That's not straightforward. All
Yeah.
right. Dr. Banjoko.
Yeah, for us again, as a licensed marriage and family therapist, it's more again, like I said earlier, we're coming more from a systemic view and trying to meet the person from a holistic point of the idea of person-centered care. So meaning that we use a lot of modalities, a lot of techniques. So we could use CBT, DBT, Bowen, strategic, narrative. So we cater to the client's personality and their needs, and we use the modalities that work for them. Or for some people, they go to specific therapists that specialize in certain modalities. And we can diagnose mental health disorders using the DSM-5 or the ICD, but we cannot prescribe medication. That's where you come in. And for most of us, we do not do assessments. We could, some of us do assessments if we're trained in those assessments, but typically if we want to get another point of view or a good assessment done, we would send them to a psychologist or someone else to, of course, or a psychiatrist to get tested and to get maybe a differential diagnosis or to be on medication because they need it.
All right. And what is different about social work?
So to
Mr.
begin,
Audain. Yeah.
thank you, Courtney. To begin, I want to say there's more similarities than differences than what a lot of people mentioned. I think meeting the clients where they are. I thought that was our only mantra, but it actually is,
See?
marriage and family therapy, and you mentioned it as well, Courtney. But I think one of the things they really tried to drill into our heads in school was checking our biases at the door. So again, when we're looking at our hierarchy of needs, Maslow's hierarchy of needs, or we're looking at the biggest presented need of meeting someone, right? Um, what do we need? What do we need to do to accomplish that? I think social workers, we understand that, okay, we see our limitations and understand that sometimes our main job is going to be helping our client find exactly what they want. And that may not be us providing therapy. That may be us guiding them to psychiatry. That may be us guiding them to psychiatry and therapy, or a specialized kind of therapy. I think understanding where we are bias wise also helps us understand that we don't need to have all the answers, although many people think we have all the answers, but we're going to try to find them, and we're going to try to link them with people. And listen, even if we do have some of the answers, but we have our own biases that are going to get in the way, we're totally cognizant. Our field pushes us to be cognizant of where we are so that we can best help our clients and their needs.
Yeah, absolutely. And I think that, well, I can't speak for anybody else's field, but we do that as well in psychology. We try to make sure that we are provide cultural competency in our care. So making sure that you understand that the things that might be important to me, or that my values might be different from somebody else's values, and understanding their values, and the diversity of needs and cultures that people present with is really important towards being able to find what kind of intervention will be most helpful for them. The thing that is different from psychology versus some of the others is, as Dr. Banjoko said, we do assessments, we do evaluations. That is one of the big things that psychology does that is quite different. I know that psychiatry does that, but I don't think that that's the focus of psychiatry, is not necessarily evaluations. And in particular, neuropsych, which is what my specialty is, we do a lot of brain behavior, very targeted kinds of assessments and evaluations to make sure that we're finding out if there is maybe a biological or neurological issue that is contributing to their psychological presentation. And if so, ADHD, autism, and then obviously complex psychological diagnoses like schizophrenia, bipolar, and things like that. That's a psychological assessment, but neuropsychological assessment is usually like intellectual disabilities, if somebody has a learning disorder. And so those types of differentiations between issues that somebody might have, Alzheimer's or vascular dementia, we would be the people who are giving those evaluations. And so sometimes people will try to find someone to do that, and they don't know that that's what psychology does, and that's primarily what neuropsych kinds of things that we do. So I think that that's a little bit different. That makes us sort of unique in the mental health space. And obviously, both nurse practitioners and psychiatrists, you are able to prescribe medicine. We don't prescribe medicine. That is not something that we do. For the most part, I think that it's important for people to kind of know that, so that when they're calling somebody's office, they know that this is the person that I need to get, and not this kind of person that I need. And there's lots of times where I'll have to refer again, like I said at the very beginning, and say, hey, I'm not the person you're looking for. You're actually looking for this person. So I'm really glad to hear you guys tell me like what are the things that you all do, so that I can know now next time, like, hey, you can go to a marriage and family therapist, you could go to a social worker, you can go to a clinical counselor, and that's the person that you need to go to instead of calling me. So a lot of you skipped forward in our questions that we had about education. And so go ahead and reiterate for us, what is the education necessary and training in your field? So we'll go ahead and start with Dr. Banjoko. Go ahead. Tell us what's necessary to get to where, if I am a student or someone in a second career and I want to do what you do, what do I got to do?
Well, the good thing is I came from a second career, so I know it's possible. So my first background was I'm a registered dietitian, and then I went into therapy. And so I got a master's. So I went and got a master's. A lot of times you need a master's. So I got a master's in marriage and family therapy. Then I went further on to get a PhD in systems, families, and couples. But again, a master's is adequate. During the master's program, though, you will have to do a certain amount of hours. So in my program, I had to do 500. In the program I'm currently in, it's 280. Just as a trainee, we call it a trainee. And so what it is that you have to go to something called practicum, which is basically an internship, and you have to accumulate a certain amount of hours after doing some core classwork. So you're not just going in blind, but it does feel like you're going in blind. I don't know, I can't speak for the rest of y'all, but my first time doing it, I thought I was gonna just destroy people's lives. But you're actually more equipped than you think. And so again, you do that, you do a certain amount of hours, and then you are done with that in your program. And once you're done with your master's, then you register for an associate license, which allows you now to see clients, but now you can see them a little bit more broadly, because while you're a trainee, you can only see clients within anything that is non-for-profit, is nonprofit. Then now you can go into other ways, and then you can specialize in certain things. And so you have about 2 to 6 years to gather 3,000 hours in the state of California. But you can count some of or you can count your hours from your master's. So that's the plus about the MFD route. But for the LPCC, for example, once you graduate, you start counting from number one again for the 3,000. And so you go into that, you collect your hours. I strongly suggest that you use that opportunity to go into different fields. I think I worked at 5 different places and got like different types of backgrounds just to know what you're into. Because I thought I was going to do children, and I have not worked with children since. So this is great practice. So for those of you that see children, thank you for your ministry. And and then you get your 3,000 hours. So before you finish your 3,000 hours, you have to take the law and ethics exam, which is basically a short examination on law and ethics, because you have to know law and ethics because our job is very delicate. And so then you finish all that, then you sit down. Once you're done with your 3,000 hours, then you can sit for the licensing examination, which is 4 hours of multiple questions of just like vignettes and things and ideas. And once you pass that, then you're licensed and then you can live your best life. But of course, through all of this, you are doing supervision and getting supervision. And once you're licensed, you no longer have to do supervision. But I will recommend that you should always be part of a consultation group, because you should never feel at any point in your career that you know everything. Once you get there, you should probably like dial back and reevaluate. But
and
yeah,
and you guys have to do continuing education, right?
and there is a lot of CEUs. I think for every 2 years, we renew our license every 2 years, and you have to have 36, I believe, every 2 years to be able to renew.
Okay. All right. So how, if I wanted to go uh the nurse practitioner route, what would I do to get there? How do you become what you do?
So yeah, so for the nurse practitioner part of it, like I was saying earlier, I was just one of the ones that jumped ahead. It requires a master's in the science of nursing. Some of the fields of nurse practitioner require, I think I want to say about 1,000 hours in the field, and then there's a couple like teaching that don't require any time with patients. Sorry, my cat only cares about me when I'm trying to talk to somebody else. Literally the only time she could. But yeah, so a master's and a licensure exam. We use several clinical hours. As far as the cognitive behavioral therapy aspects for insomnia, I was actually trying to look it up today because I know that they've recently opened it up to, to other fields. I think just a licensed nurse actually can do it now as well. There's several different certification programs out there. I just recently completed one through the university in California. And it was like a 3-day workshop followed by 6 months of weekly consultation meetings where everybody discussed their cases, and that was really helpful. And they offer continuing ongoing consultation groups, which I'll eventually would like to go back to as well. But so yeah, I think that kind of wraps it up.
Well, I will let you know, for psychology, you have to have a bachelor's degree first, and then you go to a doctoral program where you can get your master's degree en route to your PhD, or PsyD. That's either a 5-year program or 6-year program. During that time, you have to do a master's thesis and then also a dissertation. And you have to do, as you were saying before, clinical work with practicums, where you're at either a private practice or you're at a hospital and you're learning alongside somebody who is a professional, and you are being externed by them. That is not an internship, is an externship. Then you do an internship where you are working at a place where all you're doing is that specialty of whatever you've chosen. And after your internship, then you graduate. In It's interesting because the medical model, internship is equivalent to fellowship, and they actually take it after you graduate. We still have it before you graduate. And then after you graduate from your internship, then you go on to, if you do a specialty like I did in neuropsych, you have a postdoc that you have to do for at least 2 years, where you're working specifically out in the field. And this time you get paid. In the externship, where you're still a student, you don't get money. Internship, you get a little bit of money. Postdoc, you get some money while you're getting trained. You have to do a 4,000 hours so that you're able to do neuro. And our training is very much brain behavior relationships. And I know that I had someone who asked me, oh, I want to do what you do because they see that I do these assessments with kids. And they said, but I don't like science and I don't want to go to school for a long time. I was like, baby, you don't want to do what I do. If you don't like science and you don't want to be in school for a long time, you need to do something else, because that is not the right field. But then after you finish that, you can take your licensing exam, and that exam is to say that you are competent enough, the EPPP, you're competent enough to practice. But then you have to, so that exam is an exam that says that you are competent enough to get a license, but that is not the licensing exam itself, because you have to then go to whatever state you're going to, and at that state, then you have to apply for a license in that state and pass whatever exams that they have. Different states have different requirements. And then you can have an actual license. And you have CEs some states have every 2 years, some states have every 3 years, but every so often at regular intervals, you have to acquire a certain number of continuing education credits so that you can remain competent. So you're not just out there just doing craziness. And because this is what you learned way back when, you need to be up on the latest kinds of things. So that's sort of the trajectory. It's a long trajectory, but it's not quite as long as psychiatry. And if you could tell us how you get to be a psychiatrist.
Sure thing. So after your college requirements, when applying to medical school, usually you take a test called the MCAT, which is the test that is looked at when you're applying for medical school. Medical school is about 4 years if you don't have any setbacks. And during that process, there's 2 major tests of the 3 major ones before you can apply for a license. You have the USMLE Step 1, which is taken after, I believe, if I remember correctly, after the 2nd year of medical school. And then you have USMLE Step 2 after the 3rd year. The first 2 years of medical school, it's kind of like learning a language. You're in classes kind of similar to what you're used to through your college experience, where you're going to a classroom, you're learning specific subjects, and then you're going to be tested on those subjects. They just come at a higher volume at that point. After you kind of learn the language of medicine, then you kind of learn kind of the structure of it when you do your rotations in the 3rd and 4th year. And you're rotating usually through the different fields, so you can kind of get an idea. You have a certain amount that you need to do in your core, which is your 3rd year, and in your 4th year, there's the leftover ones that you didn't get in the first set of rotations, and then some electives where you get to kind of, once you kind of have an idea where you think you want to specialize, you can kind of pick some more electives to kind of lock that choice in. If your goal is to make sure you pass your USMLE Step 2, because you need that to graduate. And then after that, when you graduate from medical school, you then go to residency. This internship is the first year of residency. Sometimes certain residencies, you have to do an internship year separate and then go to the residency. A lot of times it's infused into the residency. For psychiatry, it's a 4-year residency for general psychiatry. And so after your first year of residency, then you're able to you're qualified to sit for the 3rd step of the USMLE, which has to be passed before you can apply for your license. The time crunch comes in there because you need to be licensed by the end of your 2nd year to be able to continue in your 3rd and 4th year most times, because you need to be a senior resident to continue the 3rd and 4th year. So that's where you kind of get a little pressure. I mean, there's pressure on each of them to not have to be held back at any of those steps, but that one's kind of a big one. And then after your residency, if you want to specialize in child psychiatry, that's another fellowship for about 2 years after that. Now, if you want to do child psychiatry from the beginning, like I did, you can opt to fast track it, where you can actually complete most of your core features in the first 3 years of residency and then apply for a child fellowship. And you can actually complete the entire internship, residency, fellowship part in just 5 years. So that did help. Knowing what I wanted to do going in. But usually, if you just went through and then figured that out later, it would take 6. Now, some of the other fields in psychiatry, I think they're usually 1 year fellowships. So usually 5 if you want to specialize in anything else. But once you finished all of your training, then you're able to, you're what we call board eligible. And then after your first year, I think after you finish, then you can go and sit for your boards. So after your residency, and you usually start your job as board eligible, and then after a year or so, you can apply to take your boards, become board certified. And so that is the process.
It's a long process even you talk about. But no, it's good to know. I always tell people that, you need to know what you're getting into before you do it. And so counting the cost before you go ahead and start anything is important. So definitely.
I would say, the one thing I would say, it is a time commitment. Okay. But one thing I always tell people who say, because a lot of people say, I want to do what you're doing. I say, look, if you know you want to do it, and then they hear about how long it takes, and then they get discouraged. I say, look, don't worry about how long it takes if you know what you want to do. Because, the time's going to go by anyways. Mm-hmm. So you might as well be what you want to be at the end of it. So the process is just the process, and the time is the time. But if that's what you want to do, you don't want to be regretting that you didn't do it at the end of it, because I would have been done by now. Yeah, that time's going to go by no matter what. So you might as well, go for it and just understand it's the process. And the thing I'll say is, when I finished it, and I wish I knew this before, the journey, the process of it all, all the nights in residency, those are the most important parts of becoming a doctor. So like at the end, I kind of was like, all right, what's next? I'm very driven. So I was kind of like, what's next? Looking forward to the next thing. I did not appreciate the process while I was in it. And then by the time I got my board certification, I'm like, all right, this is I'm done, kind of thing. I was all excited, like, oh, I finally finished, and like 30 minutes later, I'm like, well, now what? And, and I'm like, I kind of missed the process, and a lot of times we don't enjoy the waking up at 2:00 in the morning to go see the patient that the police was brought into the emergency room. We're not enjoying that at the time, but like that's the things I remember the most. When I tell my stories about my journey, that's the story I'm going to tell. Those are the things that made me remember all the things that I knew. And so I didn't enjoy the tough times as much as I should have, or appreciate the tough times as much as I should have. And, that's the other thing I was saying, the process is actually, all the challenges of the process is the value of the process. And so anyone who's looking to go into that, don't worry about how long it takes. You'll get there when you get there, and enjoy the process through the ups and the downs, because that's where the value of your education is at. So.
Awesome. All right. The field that I know the least about probably is counseling, and licensed counseling, and also life coaching, and how you become that. And so tell us a little bit about that.
Okay, sure. So it's a little bit similar to what Dr. Banjoko spoke of her pathway. So, after your bachelor's degree, you would enter a master's program. I think I shared a little bit earlier that the counseling program is through the School of Human Development and Education. And through that program, at least when I was going, there were 3 different counseling pathways you could choose. There's rehabilitation counseling, school counseling, and at the time I went, community counseling. I believe now it's mental health counseling. You would need to, within that program, get about 60 credit hours of coursework, including practicum and internship hours. So depending on if you are attending a KCREP accredited program or not, would determine how many pre-graduation hours you would need. And again, that is, you are practicing the art of counseling at a location, a hospital, a school, a counseling center, and you're getting supervision during that time. And in our program, we also had a counseling center that was attached to our program, where we were able to get observational support, which was really great just for learning. And so, again, depending on the type of program you attend, I attended a K-CREP accredited program that allowed me to take a national licensure exam. And again, at that time, I was able to get sort of a national counseling certification. I believe now the programs you are coming out of school with your 60 credit hours are able to take a national counseling exam along with a state laws exam, again, similar to what Dr. Banjoko mentioned. And then you would be able to get a graduate license. And so that graduate license allows you to then practice or work under the supervision of a clinically licensed mental health professional. And you would then do that until you get a certain amount of supervised working hours. In the state of Maryland, it's 3,000, I believe, total. And we were able to include our pre-graduation hours. Again, it depends on the program and the accreditation of your school. So after you get those 3,000 hours, then you are able to, if you have already taken the national certification exams and the state laws exams, then you're able to apply for your clinical licensure. Now, because coaching does not require a professional pathway, technically, people can call themselves coaches without needing any additional education or experiences. I don't recommend that. So that's just me. So for me, because I was trained as a professional counselor first, and I've been doing that for a while before I started looking into expanding my practice through coaching, I opted to do a coaching training program specifically designed for folk who are already licensed as counselors. For us, the necessity was to understand the differences between mental health counseling and life coaching so that we could clearly distinguish between the two services and understand what we're providing and how we're doing that work so that we're not inadvertently slipping into counseling when we're supposed to be doing coaching. And so that was sort of the nature of the coaching program I got. But there are several. There's the International Coaching Federation. That's a certified body where you're able to locate coaches that have gone through training programs, which I do recommend to just have somebody who knows what they're doing. And there are several coaching training programs that do not require you to have sort of a license or a master's degree in sort of counseling or another mental health field, that you can, again, get specific training based on the type of coaching that you may want to provide to someone. So, yeah.
Awesome. Awesome. Last but not least, what do you do to become a social worker? What kind of training is involved and what's the road?
Sure. So first, there's three levels. There's a undergraduate or baccalaureate level. There's a graduate level, and then there's a clinical level after that. Just to break it down pretty simply. So throughout all the stages, like was mentioned with counseling and with marriage and family therapy, there's a lot of supervision that is required, and there's a lot of internship hours that are required. So after the baccalaureate level, Dr. White spoke about fast tracking. So let's just say, a student were to go through and get a undergraduate degree in social work. That would be the fastest track in becoming a master's level social worker. At that point, they would only need one more year and a summer roughly to get their master's degree in social work. After or towards the end, right, of your master's degree in social work, you take a state examination, again, much like counseling and marriage and family therapy, a 4-hour state exam that allow you to essentially, practice under supervision in your state, right? The state laws kind of differentiate somewhat, but that will allow you to basically be supervised to practice clinical social work. The thing about social work that may be different, there's an advocacy component. There's a component that you may, work in a different way. You're not necessarily seeing clients, one-on-one or in groups. You're working in different places. And that's why the third level, the clinical level, is a little bit different. The clinical level, again, like counseling and marriage and family therapy, it requires 3,000 hours of work. And of those 3,000 hours, you need to have 150 hours of supervision, or 100 hours of supervision. And 1,500 of those 3,000 hours need to be face to face with clients in order to get your clinical licensure. And those are for the social workers that, again, want to do therapy, psychotherapy in the future. That's kind of the requirements. And at that point, after they've finished their hours, they submit it to their state, and they take another exam, right? They take another 4-hour state exam, and that will allow them then to bill insurances, to be able to open their own practice, and to be able to operate independently as a social worker. So essentially 3 different levels, lots of internships. But again, like Dr. White said, those are the times, right, that you really build. And again, I think Dr. Banjoko mentioned that the different areas are super beneficial in growing you as a clinician. I remember my first, and I think we all remember our first. I was working in a homeless women's shelter in DC, in the District of Columbia, and the amount of different diagnoses that I was able to see and to work with really built me as a clinician. Being able to see what, depression looks like, but even other borderline personality disorder, schizophrenia, being able to see that as a very young student and being able to work with that and understanding that was priceless. And again, the stories, that's what you're able to take and again, learn and use in your future practice. So that's key. So lots of internships, but solid tests, obviously, to show your competency. And when you come out, it'll be worth it. The time will pass. I use that all the time, Dr. White. The time passes whether you like it or not. You might as well do what you want. Do what you want, because it's going to make the difference in the end. Because if you love what you're doing, you're not really wasting any time, right? You're following your passion. And more importantly, hopefully you're following your calling, right? And so you're going to be in the right place.
Absolutely, absolutely. And we have some questions in the chat that we're going to get to. If you are watching here live, go ahead and ask some of your questions now. We're going to get to those in a second. I just have one more thing, just piggybacking off of the idea of passion. Everyone, what is the thing about your field that you think is the best? What do you think is the most enjoyable, the most fulfilling? For me, I personally love the variety that psychology gives, to be able to see so many different types of people in so many different situations. So, like I said, I do lifespan, so I get to see a wide breadth of people and a lot of different clinical presentations. So I feel like I have a lot of options. And I felt that even when I was a trainee, that there were a lot of paths that I could take as a psychologist. And I think I enjoy that the most, to be able to have so many different places that I could take that experience and use that in my field. So I'm not sure if we'll do, whoever wants to go first, go ahead and let us know what is the best thing about what you do, in your opinion.
I guess I'll start since there's silence. Change. I love to see change. I love to see when my clients choose to change. Again, our job, our work is client driven. And when a client decides to change and to put to work some of the things that we've been working on, plus what they want, it's a beautiful thing. I say self-determination is my greatest ally and my greatest enemy. I know that nothing can happen unless self-determination takes key. If my client decides they want to change, that's beautiful. If not, we're going to be banging our heads against our wall for longer. I enjoy the process. It is a process, but seeing change is what makes, my profession probably most rewarding.
All right.
I'll piggyback.
Oh, no, go ahead, Anthony.
I was just going to piggyback. Working in healthcare, mental health, having the opportunity to watch people get better. There's no greater feeling, and being lucky enough to get paid for it is, I don't know, I'm very grateful for that. The only thing I'll add to that is working in healthcare, you're always, we think that our problems are so big all the time, especially when you're in them, but being to work with so many people and you're always kind of reminded that somebody has it worse, and it really makes your problems feel small on a daily basis. So I don't know, I feel very lucky for that, and thanks again for having me here.
All right.
I love being able to walk with people. I tend to do longer term therapy, and it's been such a gift to be able to see people through different phases of lives. I get really stoked when they start standing up for themselves and they find some boundaries. They get a little bass in their chest in ways that are really supportive. It's super exciting for me to see that from people, because I work with people who come from doing and doing and doing and being for everybody else. So I get really excited when they start to get, self-supportive and find that strength. Yeah.
Awesome. Awesome.
I would say that, personally, on a personal level, I agree is the changes that we're allowed to make with families, and especially with children and young adults, where you can make changes that they can carry forward in their life. I would say field specific, as far as psychiatry is concerned, I think the flexibility that's afforded in being trained in all aspects of mental health is a benefit, although it does come at the cost of the time commitment required for it. But I think just our abilities to be in the lives of people and to help see them change and to get better is the best part.
Awesome.
Yeah, like everyone said, I think it's just watching like that aha moment for the first time, or seeing like, because like Karla, I do long-term therapy too, and to be like, wow, to see what's happened in year 1, year 2, year 3, year 4. Like I've seen clients from like really struggling to now they're like telling me they're getting married, and it's just so rewarding to just have been a part of that and to walk alongside them in that way. It's such a privilege. And I think as an educator too, it's just nice that I can pivot. I love the fact that with MFT, I could kind of pivot. I went to MedFT, I do sex therapy now. And so it's just nice to see that there's so many ways. So I don't have to do the same thing. I could get into my 50s and 60s and be like, I want to go into geriatric. And so there's just so many parts of it that I just enjoy, and how it just continues to allow me to evolve with my clients is just a plus. So.
Well, just like you were saying, thank you to the Ministry of those who do pediatrics. I want to thank those of you who decide that you want to do long-term therapy, because that is not my ministry. Long-term therapy is not something that I enjoy. For being with somebody for years and years and years, whew, there's nothing I would like less.
You gotta know your limits.
We all
Yes,
have our
yes.
callings.
Yes, I like doing an assessment, and here you go. Bless you. Here are your accommodations, and I like hearing what happens later. I like people coming back and talking to me later, or if they need a reval, and we do a reevaluation. It's fine, but we don't need to do therapy for years. Not for me. Not for me. Bless you all. Bless you all who do that. So we have a few questions that are in the chat. One of them is, what are the top 3 easy? I think this is for you, Anthony. What are the top 3 easy to do remedies for adult insomnia? Somebody wants to know. So,
Oh goodness. Yeah, I don't know if there's a top 3 necessarily, but a lot of what our treatments, it's pretty structured. I guess that's a little bit different than some of the traditional counseling that everyone else does here. And I guess I didn't mention earlier, it's usually about 5 to 8 sessions. During that time, only a small percentage kind of really improve their sleep, but what the research shows is following them for a year after is a lot higher percentage of people. So basically, a lot of what we teach, you apply long term, and it gets better over time. Unfortunately, there's no pill or quick fix to this kind of thing, but a large part of it I explain is kind of reconditioning your bed for sleep. A lot of people that come to see me, they're spending a lot of time in bed doing stuff besides sleeping, whether it's TV, phones, games, or just staring at the ceiling, tossing and turning. You know, and the way we fix that is by only using the bed for sleep. You know, and another big part of it is getting out of bed if you can't sleep, which seems kind of counterintuitive to some people. You know, what the research shows is after about 20 minutes of not sleeping, you start to associate your bed with being awake. So when that time comes, we actually encourage people to get out of bed, go to another room, actually keep it low light, do something boring. You know, another big one that kind of goes along those same lines is only going to bed when you're sleepy. You know, which sounds kind of common sense, but you know, when you're struggling with sleep, you think, oh, I need to go to bed earlier so I'll have more opportunity. And really what you're doing, and when you do that, is kind of making the problem worse. And then just to kind of what I mentioned earlier, a lot of it's based around like relaxation type stuff, really protecting that hour before bed, shutting down from anything stimulating, phones and the work. And TV's okay, actually, if it's something you've seen before, but usually what we'll have patients focus on is a lot of those breathing exercises and meditation type stuff, guided imagery. You know, they say the worst thing you can do is try to sleep. Supposed to let it unfold naturally, whatever that means, is what how I usually follow that up with. But so yeah, I think that's the main part. Not napping, of course. You know, it's you know, it's kind of like our sleep drive. Yeah, right. I mean, keep it under an hour is what we tell people, or 30 minutes or less. Anytime you nap longer than 30 minutes, you're getting into your deep stages, and that, you know, it's kind of like eating a snack before dinner. You know, you kind of kill your appetite.
Right.
Getting up at the same time every morning is real big. Our circadian rhythm's a big part of what controls our sleep. The way we do that is by having consistency. But yeah, I think that's probably all back to relaxation. You know, it's really I think the best thing I can give people is, you know, how to relax, especially a lot of our, you know, our mind's always going. It's real common to hit the bed and have that mind racing thing. So
Yeah. Gotcha. Well, we have some more questions here.
I just
We want
piggyback
to get through. Oh, yeah,
I
Bill.
just piggyback on, you know, he did a great job of explaining, you know, what we call sleep hygiene techniques. The only other one I would add, you know, just kind of like a quick thing, is really controlling the light in the room when you go to bed. So if you don't have like blackout curtains, those little night things that they put across the little, those work miracles sometimes. Those can be very helpful. So that would be another, you know, just a recommendation that I often share as well, along with the other sleep hygiene techniques that Anthony mentioned.
Awesome. Awesome. Here's another question. How do I find a good clinician? And how do I find somebody who matches with me? That's a pretty big, broad question. Anybody want to take that? Go ahead.
I'll just start off by saying that there are a lot of websites now than back in the day. So if it's so overwhelming, I would say a good place to start is Psychology Today. And I think they're in every state. So I know that's a valid one to go with first. And another thing too is knowing what you want to work on. And I know for some people that's overwhelming. And it doesn't mean like you have to like, oh, I'm working on this part of my trauma, but it's just knowing like, okay, do I want to work on anger? Do I want to work on being a better human? Do I want to work on I feel like I'm depressed. I just need somebody to confirm that. Like making, like knowing exactly what you're looking for and being okay with the fact that you like what you like. So if you're like, I only want to work with a Black person, that's okay. If I want to work with a white person, that's okay. Like, I want to work with someone who speaks Spanish, that is okay. Like, this is for you and this is your service. And kind of like you were saying earlier, like, think about it as dating. Like, of course, if you go into the first session, I always say, you know, give it more than one. But if you go into that first session and you're like, this is not for me, it is okay. Like, we are also trained to tolerate and accept rejection. Like, we will be okay. If you don't like us, we should be able to refer you out. And if that person has an issue with letting you go, that person was never your person anyways, and they should not be for anybody else either. And so again, recognizing that, you know, not every therapist is your therapist, like not every client is my client, and that's okay. And just finding the person that works for you, like for real, and you're allowed to leave if you don't like them. More than anything, I want you to know you have agency when looking for a therapist.
Yeah.
Absolutely.
Yeah, I just want to, piggyback on that and co-sign absolutely. And add as well, if the therapist does consultation calls, absolutely take advantage of that. That's something that I know I do in my practice because I'm also looking for a good fit. I've learned, because I've worked long enough, who I work really well with, who I could connect well with, and so I target those people in sort of my sort of written website. But definitely asking, hey, is it okay? Do you do consultation calls? Can I, schedule time to talk with you for a few minutes to check out the fit? And even after that, if you go in, you do the first session or you do a couple of sessions, you're like, it's not clicking the way that I thought it would. Absolutely, you can leave and look for somebody else. And a lot of the, Dr. Banjoko also mentioned kind of psychology today. There's also therapy for Black girls. There's inclusive therapists or other ones I would also recommend. And some of those have filters. So you can look at the issues. So like anger, depression, sadness. You can filter by, again, like race, languages, orientation, if you're looking for an LGBTQIA plus friendly, therapist or things like that. So those tools can be really helpful to help you target before you have to talk to somebody. Because if you're also introverted, you may, want to see what you can learn online before you actually have a conversation with somebody.
Very true.
I would also add, again, if you're going through a listserv, you can send messages. I would send messages to multiple clinicians that you're interested in, because depending on most of us.
This sounds like a dating site over here. Like Tinder or something.
Yeah, send multiple messages. Because a lot of us are full, and a lot of good clinicians are often full or have waiting lists. So if you send multiple to people that you feel like could be a good fit, it's going to increase the likelihood that you get back a response from at least one or two of them sooner, and kind of move you into therapy a bit quicker. So yeah, those are some things I would add.
Okay. All right. I know somebody who should be in therapy, but they don't want to go. What should I do? Anybody want to take that?
First, I want to say that I can't count on one hand how many moms, sisters, brothers that have called. And honestly, when I said self-determination is my greatest ally and my greatest enemy, they have to get to that point. Sometimes I've seen it work, but most times, if we're going to be effective in our work, they have to be willing to take that step. This first step is the hardest. I say it all the time in finding a therapist, but you get through it. There's hard work to come, but the first step is one of the biggest. So if they're in your life, encourage them by all means. But you doing it by themselves, calling, it's not really going to take hold until they believe themselves that this is the step that they want to take. That self-determination. I am tired of where I am, and I want to move forward. When that takes place, then that's when the magic can begin to happen. So encourage them, but them taking the step is going to be key. That's my opinion from my experience so far.
I would add that when it comes to therapy, one of the misconceptions is that you have to have a problem to benefit from it. Okay. Yeah. And so I think that's one of the things that, people start realizing that therapy serves purposes other than just, it's a skill building process. It's an exploration process that's helpful at any stage. Usually when I'm talking to, people about using therapy, I explain it in a system like, I like to relate it to something they're familiar with. If they're into sports, I talk about, hey, if you like to play basketball, it doesn't matter what level you're at. If you have never played, you need to go to a skill building situation. You can get some basic skills. If you're an excellent basketball player, but you want to be elite, you can still go to skill building and get those. So looking at therapy as something that is a skill building process that can improve your situation, whether you have a problem that needs to be addressed, whether you just want to, performance enhancement in any aspect of your life. There's so many ways that therapy can be helpful for anybody, that if you present it that way, then it's a lot easier for people to be more receptive or acceptable to the idea of going to therapy when they understand that it's not just because you have a problem.
Yeah, and I think that stigma definitely does keep a lot of people from seeking mental health services, because they think that it means that something's wrong with me if I have to go. And that's not the case. Thank you for saying that. Yeah. All right. So in our last few minutes, I'm just going to ask anybody, thank you all for being here. Where can we find you? Do you have a project or something that you want to promote and want to share with the people, I will let you know that I am writing a book on mental health and faith. It's called Just Pray More and Other Church Myths About Mental Health. There's a lot of people who think that all you got to do is pray more and you can defeat any kind of mental health issue. And so this is kind of breaking down some of the myths, some of the things that you guys talked about today as well. And if you are interested in getting that book, I'm going to put a link in the description below so that you can go ahead and sign up to get a coupon code and information as well about the book when it comes out, about pre-ordering and getting that. And so just letting people know about that for me. Anybody else have anything that you want to present to us that you're doing, that, or maybe just somebody else's things that you want to promote and help people to know about? Anybody want to start?
Sure, I guess. I'm always looking to grow my practice. So if you are passionate about young people and kids and you're looking to work in an environment to make an impact, in our world, then send me information. You can find me on Psychology Today.
All right, awesome.
And just like Jean, I am also in psychology today. Right now, I am currently practicing if you're looking for anything in terms of sex therapy, and I am trained in Christian sex therapy. And so, in any way like that, definitely please look for me. And also, if you are watching this and you are interested in becoming a marriage and family therapist or a professional counselor in the state of California, please look at our program. It's called the MA in Counseling at La Sierra University. And of course, like I said, I'm the program director. And if you shoot me an email, I love to tell you all about the wonderful world of becoming a therapist. And I'm also on Instagram on Dr. Sandra Banjoko, and I'm actually working on a project that I hope will come out soon. I'm starting a podcast on talking about sexual stuff from a faith perspective, but with a lot of empirical knowledge. And
All
Excellent.
so,
right.
yes. So, yeah, so stay tuned.
Okay.
Mhm.
Awesome. I'm also on Psychology Today, and my website is grow-joy.com. Yeah, that's where you can find me.
Short, sweet, and to the point. And you said that you take a lot of different kind of clientele, right?
I do, yes. So yeah, working with 18 plus, my compassionate women and soulful introverts. I do serve a lot of Black women, as that's an experience that I am familiar with. And also just there's a lot of dynamics there. I also do a lot of intersectionality work. So people who hold one or multiple minority identities. Um, and kind of the impact of that is also an area I have a lot of interest in as well and support people with.
All right, great. Um, Dr. White. And what I'm doing right now is I am writing down some of these links that you guys are telling me about, so that we can put them in the chat. And so those of you who are watching either on the replay or live can look inside the chat, and they will also be in the description once this is uploaded. I'll put everybody's links so that you can find them in there as well. So go ahead, Dr. White.
I'm not promoting anything today.
Well, promote yourself.
I don't know. I've said a lot already.
All right, that's absolutely fine. That's absolutely fine. And go ahead, Anthony, if you want to share with us something that you're doing as well.
I also really don't have anything to promote, but I just wanted to encourage people to, to continue to fight the stigma around seeking mental health. And, I think the way you do that is by talking about it. And, I hope everybody has the courage to go out and talk to someone. And what do they say? Every good counselor has their own counselor as well. So
They certainly do, certainly do. And I know that it has been helpful to me to have somebody who is who I can look to for different things. So I know that that's been a blessing in my life for getting just working through issues and things like that. So Thank you guys so much for
Thanks for
all
having
of
me.
your help in getting this information, very valuable information. I think that everybody should be interested in finding out about. Those of you who are watching on the replay, like I said, you can look in the description and you'll find the links to everyone's information underneath there. And I want to thank our audience who has been live, who's asked questions, and who sent in questions from beforehand. And if you have any questions about mental health, therapy, just in general, how to practice good emotional hygiene, I'm sure that any one of our presenters would be happy to talk with you. And don't hesitate to reach out. Thanks so much, everyone, for being here, and have a great afternoon. Stay well and be in good health.
All right. Thank
Thank
you.
you. Bye.
Bye.
Bye, everyone.